laughed. She's like, I guess that must have hurt me. So it was more uncomfortable than I thought.
Yeah, no, it's not pleasant.
Yeah.
All right, guys. So yeah, you will have the trainer tourniquets, the wound cubes. I'm not gonna get out the actual like wet wound pack until next week for lab days, but those are available for y'all to practice with after class and for lab time. So, all right, face and neck injuries. All right, let's go over a little bit of A&P for the head and the scalp. So the major facial bones you guys need to know are what? Okay, so the zygomas, right? What do they help form? So your orbital socket, okay, if we have significant breaks or compromise to the zygomas, what might we be worried about? Yeah, status of the eye, hitting those optic nerves, maybe affecting vision. What else? All right, so the maxilla, okay. Potentially, if we have significant compromise to the maxilla, what are we worried about?
Airway obstruction.
So maybe airway obstruction, right? Because that's the hard palate of the roof of your mouth. So significant blood can cause airway obstruction, maybe pieces of bone, all that jazz. What else? Mandible. All right, we'll talk about that. What am I really concerned with mandible fractures or compromise? Maybe airway. If I've got a jaw fracture, maybe some teeth might be involved. Blood again, but yeah, those are also really painful for the patient as well. Your upper nasal bones again. Airway. Okay, so I'm kind of getting a theme here. All right. Put that later. All right, so our neck, we've already talked about pretty lengthy about the spine, right? What composes the neck? What aspect of the spine?
Spine.
Cervical spine. All right, how many vertebrae do we have in the cervical spine? 7. Remember you eat breakfast at 7 a.m.? Okay. So we also have musculature and vasculature aspect of the neck as well. All right, so we talked about we should already know that we have carotid arteries bilaterally. All right, guys, what is the neck for what it is? It's very important to the body, right? Okay, we have that beeline perfusion tract to the brain. It's an essential part of the central nervous system. Airway is right here, but it's what?
Squishy.
Kind of squishy, okay. Pretty small. It's pretty vulnerable for what it is, right? We've got some of the muscles that help protect those major vessels and the airway, but for how vital our neck is to surviving, there's not a whole lot of protection, all right? So that makes it prone to injuries, and because of what's located in the neck right here, we can have some pretty life-threatening injuries to the neck, okay? Going back over our larynx, what is this right here? The thyroid cartilage. What does it help protect? Okay, so vocal cords, and the vocal cords are the gateway into the trachea, all right, so the lower airway. We've also got the Adam's apple. Remember that our trachea is made up of what? Cartilage rings, right? Helps keep it open, upright every time we breathe in. That negative pressure that's created in the chest, those cartilage rings help keep the airway like physically open. It would collapse on itself if they weren't there. Can we injure cartilage? Can we damage cartilage? Okay, so when we talk about somebody having like a collapsed trachea, that's because those cartilage rings become compromised, right? That's a bad day, right? Because if we don't have that open structure, can you really bag a patient?
No.
Not really effectively, all right? So if we have neck injuries, we're really concerned about the integrity of these cartilage rings. All right, the eyeball. Let's talk about the eye. What is the eye mostly made up of? squishy jelly stuff, squishy jelly stuff, okay? Guys, we've got the cornea here. That's kind of like the end all be all protective kind of lens, if you will. We've got the pupil. We already know what the pupil is. What does it do? Okay, so it kind of controls the amount of light that is let into the eye that comes back here to the rods and the cones and the optic nerve and all that stuff to make sure that we can perceive vision, right? Colors, shapes, depth, all that stuff. Your iris is okay, but when I'm looking at the eye, what is iris? It's a colored part of your eye that surrounds the pupil, all right? And then back here we have different layers, particularly this retina is really, really important. It's vital to vision. If we have anything that causes like a retinal detachment or a tear or anything like that, it's extremely painful. How do you think we might be able to tell if this is going on with our patient?
Your eyes are dilated.
Okay, so pupils typically will dilate and they're not really reactive. What else? Yeah, we're gonna have major visual disturbances. Okay, so very painful visual disturbances and our pupils are gonna be affected. A lot of times, guys, what causes injuries to the retina? Trauma, particularly usually blunt force to the head. Okay, so kind of the entire head and all the structures getting that blunt trauma kind of getting jostled, if you will, can cause that retina to kind of just detach, just kind of just pop off to where it usually is located. We have our vasculature supply back here, directly correlated with the optic nerve. Yeah, guys, it's important to know we're not going to see a lot of bleeding when it comes to eye injuries. The eye doesn't really bleed a lot. All right, so when we see significant, especially like penetrating trauma to the eye, we're going to see kind of that squishy, clear, jelly-like substances coming out. All right, so if we see that, that's not really a good sign. That means that we've had some significant penetrating trauma and we need to get them to the hospital ASAP. The sclera is the what part? White part. Okay, what are some different things we can tell about looking at the sclera? Okay, so jaundice, absolutely. What does that mean? Well, what is it? How does it present? So kind of yellow tint to the sclera. That's a very strong indication that we've got some failure of the liver or some very major compromise of the function of the liver. So the vitreous humor, and there's also the aqueous humor, but that's going to be that squishy jelly looking stuff. It's clear. Trying to think of something to compare it to. I don't know, but it's just, it literally looks like clear jelly. All right, we've got the conjunctiva. What is that? Okay, so that's kind of the coating of the mucous membranes when it comes to our eye, the lining of our eye, because we can absorb either intentionally or unintentionally substances, drugs, all that stuff through the mucosal membranes of our eye. Anybody ever heard of conjunctivitis? What is that? Pink eye, right? That's where the conjunctiva, the lining, gets irritated. There's a bacteria in there. It becomes very red, it becomes very irritated. That is the technical term for pink eye, all right? We've got the lacrimal glands, the nasolacrimal ducts. What happens here? Tear production. Okay, guys, why do we have a consistent production of tears in some capacity?
Very moist.
Yeah, our eye is supposed to be moist, all right? It's in its natural habitat is a moist setting. That's why we constantly do what throughout the day? Blink. All right, that's why if you keep your eyes open, like the whole staring contest thing, people always lose because their eyes start to get a little too dry. The brain's like, nope, 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 we got to preserve the status of the eye, and we start to blink. All right, We have a defense mechanism if we have a foreign particle that comes into your eye or any of the ducts or the mucosal membrane surrounding it. What happens? Your eyes start watering like crazy. All right, the brain recognizes, because we do have sensory nerves that surround our eye in the socket. It recognizes that something is there that is not supposed to be there, and it goes on the defense to stimulate those glands to have that lacrimation, so we can flush whatever that substance is out. So, yeah. That. Talked about these. Talked about that. Questions about the eye? We're gonna talk about managing eye injuries a little bit later, but just like the structure and the function of the eye. Is everybody good with that? Okay. All right, face and neck, again, guys, our biggest concern is gonna be what? Impairment, airway impairment, okay? Whether that is teeth that are knocked loose, whether it's blood that's created, whether it's a collapse of a structure. But airway is going to be, it usually is our number one concern, right? Our ABCs for our patient, but particularly in the face and neck, that's going to be our go-to to make sure that we try to preserve that airway as best as possible. All right, we talked about yesterday, what is the face when it comes to properties and trauma we need to keep in mind? Very vascular, all right? So a laceration, a small laceration to the scalp, to the head, to the face is gonna bleed a good bit. So keep that in mind. Sometimes it can be like a shock factor where you see a crap ton of blood and you're like, this has gotta be a crazy injury. We kind of clean up the blood, we get to the source, and it's not, you know, anything but like a 3 millimeter laceration. Again, keep that in mind. The more blood, the more potential for airway compromise. What's a hematoma? Yeah, so it's typically the skin is not broken. So technically it would be a blunt trauma, but the accumulation of the blood and the fluids up underneath the skin causes like a raised, like a goose egg or a knot. Like if you hit your head, it kind of gets that raised property. That's going to be hematoma. Guys, the face and the neck is covered with skin. It's soft tissue, so it's susceptible to any of the injuries we talked about yesterday, right? Abrasions, lacerations, avulsions, these skin tears that we talked about with the geriatric patients. What would that be kind of classified as? Typically, they present with more as like an avulsion. Like they usually have like a little flap that just kind of. The flap is still hanging there. Yeah. Okay. All right, mandible injuries. Guys, what is something that we can do when it comes to assessing our patient to see if the mandible or possibly the maxilla are significantly impacted? If we got somebody, you know, got hit in the face with a 2x4. All right, we want to make sure that that mandible is intact. We can palpate it, right? But what also is the jaw? It's a bone, but it's also part of a joint, right? So typically to make sure that that joint is intact, what can we do? Right, we're going to ask the patient, hey, can you open your mouth wide and then close your mouth and then bite down? All right, if they can do both of those things physically and without excruciating pain, we can have a pretty solid suspicion that we don't have a significant fracture and or that the joint is still in place and it's not dislocated. All right, if the patient cannot physically open their mouth or bite down, we might have some problems with the joint connecting. Sometimes it's very obvious if it's disconnected or if it's popped out of place, but sometimes it's very subtle. All right, so just ask your patient, open your mouth and bite down. And that's also the biting down aspect is testing the integrity of the maxilla as well.
Will they bite kind of offset too?
Meaning,
Something in their jaw, be kind of off one side or something?
oh yeah, it can be all sorts of different ways. If it's kind of like pushed to the side, that's going to be a little bit more obvious. But sometimes if it just gets pushed down, it just might look like they have an elongated like bite
Yes, that's what I'm asking. So would you see something indicative when they try to bite down and their bite is kind of cockeyed or something?
They're not gonna be able to physically do any kind of like biting down if it's not in place, yeah. Guys, what's the treatment for a broken jaw or dislocated jaw?
Stabilize it and then take them to the hospital?
So for us, right, can we splint a jaw? Can we do anything for that? No. So yeah, what can we do? A sympathetic transport, encourage the patient to do or not to do what? Hey man, don't try to open your mouth, don't try to talk, don't try to move it around, don't touch it. All right, guys, there's not a lot that we can do pre-hospital setting for a broken or dislocated jaw. When they get to the hospital, I don't know why, this is always, ugh. The end all be all treatment is most of the times they get their jaw wired shut. Because, yeah, think about it. Day in and day out, even if you don't talk a word throughout the day, all right, drinking liquids, eating food, you know, anything like that, you're consistently having those small movements of the jaw. So they typically will get their jaw wired shut and get like an NG tube placed so they can eat. But yeah, that just always is to think about. Dental injuries. What do we need to think about here? Airway, right? If a tooth becomes chipped or totally knocked out, it can become lodged in the airway. Guys, again, the blood that is produced with these facial injuries, the swelling, the irritation of the tissue of the skin is also an airway concern. Okay, so guys, if you have any type of facial trauma, we always need to do an inspection of the teeth. All right, so either if the patient's conscious, ask them to just kind of open their mouth. If they're unconscious, we need to do probably what kind of maneuver to open the airway? Jaw thrust, and just see if we have any teeth missing. Now, is it totally possible that you could have a patient that does not have all of their teeth or any at all, and that's baseline for them?
Sure.
Yes. So what can we look for that might indicate that this is a recent trauma? Bleeding, any type of really jagged points to the teeth, because typically if you have a cracked tooth or a chipped tooth, if you've had it over some time, the wear and tear of eating and stuff it won't make the points as sharp or as jagged. But yeah, look for that irritation of the gums, jagged points, bleeding, all that stuff to see if we're, need to be possibly looking for the other piece of the tooth in the patient's airway. How can you manage that?
If it's completely obstructed, abdominal thrust.
So if we've got maybe just like a piece of a tooth or blood in the airway, suction, right? Guys, another tip for the suction is if you've got, let's say a patient's vomiting and they've got bigger chunks of food or there's a bigger piece of like a tooth, what can you do to make the suction more effective? Take the yonker off, right? The diameter of the tubing itself is wider than the tip of the yonker. So if you can't remove a substance or a piece of a tooth with the tip of the yonker, just take the yonker off and just use the tubing. Same principles though, don't place it any further than you can see. Only suction on the way out up to 15 seconds, but you can use the wider diameter of just the tubing if you need to.
Two questions. Where do you draw the line of where you can use your fingers for like figure stuff out?
If you can visibly see it and you know the patient's not going to bite you, and it's right there for you to remove it, then that's fine. But you're not going to I'm not going to put my finger towards the back of their throat or their airway at all.
Yeah, but you're not going to put the yonker from to either. Right?
Correct. But there's a higher percentage that the suctioning property of the suction machine will remove that better than I can just kind of try to grab it with my finger.
My other question was, if you have suspect C-spine injury, but they have a broken mandible, how do you still do jaw thrust there?
Very gently. You might can do a modified jaw thrust instead of displacing it here at the joint. Just maybe kind of physically opening right here on the jaw because that's a lot more forceful. But yeah, just improvise around the fracture. Okay. Okay. Does anything change about your scene size up?
No.
Okay. Anything change about your primary survey? ABCs. Guys, we might run into some challenges, like we were just talking about, maybe opening that airway if we have a fractured mandible, maybe managing the airway if we've got bits of teeth. But just remember, you know, your basic skills, the airway, ways to open the airway, your suction, your adjuncts. Probably, guys, if we've got significant facial trauma to the extent that we've got broken teeth and lots of blood and all of that, what type of adjuncts do we might want to lean towards?
And here.
Okay. Take a step back, look at your patient, because what's a contraindication for an NPA?
Nasal damage.
Okay, so any type of significant fracture to the nasal structure. So if we can, you know, do a palpate here, make sure that's intact. If we can maybe like look at the roof of their mouth and make sure we don't have an open fracture there, then we want to go with the OPA if any of those nasal compromises are present. Okay. Where are these patients going? Trauma center. What's going to be a big thing that we reassess? We do this with every patient, but yeah, during your reassessment, make sure your ABCs are still good. They're still intact. Guys, what if we have a tooth, fairly big chunk, or the whole thing that we find on scene or in the patient's airway? What can we attempt to do?
Bring it with us.
Bring it with you, okay? Ideal situation, you're at a grocery store, you're at a residence, what can we transport that in? Milk. Okay, milk is very calcium rich. It helps preserve the properties of the tooth. So if somebody gets into, you know, a fist fight at their house in their front yard and they get a tooth knocked out, hey, do you have any milk? Can you go pour a glass of milk and bring it out to me? Put the tooth in there, try to bring it with you, because they can, through reconstructive, I guess it's not plastic surgery. They probably have to go to a dentist to do it, but they can like wire the tooth together to try to help it grow back together. So just, if you can and you have milk handy, bring it to the hospital. If you don't have milk handy, still bring it to the hospital. Just put it in like a little bio bag or something like that. All right, guys, what is one thing that we need to understand about the eyes and how they work? They work in unison. They work in tandem, right? We're not a chameleon. We can't look this way with the left eye and then, you know, look in any other direction with the right eye. If you're looking to the left, both eyes are moving at the same time, at the same pace in the same direction. So that being said, what do you think we want to do if we have an eye injury? Okay, so let's say I get a pencil lead stuck in my left eye, and I come on scene. What am I going to do for the treatment of that left eye? Not really. If it's like literally still sticking in the eye, we're not going to try to flush it, because what's that going to cause? A lot of rapid eye movement, right? Do we really want that if we've got a foreign object that is still impaled in the eye? Okay, so we're going to make a modified eye patch, right? I want to cover up this left eye, all right? Particularly if you have anything that is like impaled, that is sticking out or protruding from the eye, how do you think we can go about managing that? Okay, so we can maybe build like a bulky dressing around it. All right, what else can we do?
The other eye.
Okay, so eventually, but for particularly something that's protruding out of the eye. So we can build a bulky dressing, kind of like we see here. Okay, what else? Again, ideal situation, you have something like this handy on scene or with you. What can we use to try to make a makeshift eye patch? A cuff. right? Like a styrofoam cup or a plastic cup or like a regular just drinking cup. All right, we can place that over protecting the eye and protecting that object that's protruding out of the eye. And then in some capacity, we can secure the cup to the head. Guys, if it's like a styrofoam or a plastic cup, we can try to cut like the very bottom of it out just so there's just kind of walls around it. But yeah, if you've got a cup handy, use that to try, especially for something that's protruding out of the eye. But yeah, guys, we're going to put blinders on the horse, right? We're going to cover the eye that is not affected. Because think about it. Okay. It's very vulnerable when you haven't compromises one of your eyes, right? That patient is aware of what's going on. It's a lot more intimidating. It's a lot more scary. So if we've got just that one eye covered up, what do you think this right eye is going to be doing? It's going to be just darting all over the place, just kind of like looking around, just making sure that their environment's safe because it's compromised to see out of the other eye. If this eye is darting around, what is this eye doing?
Same thing.
Same thing. All right. So we want to keep them as still and as stationary as possible. So please explain to your patient why you're going to be covering the other eye as well. Okay. Because if both eyes are covered, it's less likely that they're going to be darting around in that rapid motion. All right. So we want to cover the affected eye and also the unaffected eye to prevent ideally as little as motion as possible to the eye that's injured. Make sense? Okay.
Wear yourself a nectar now. You'll get $399 worth of accessories. $365.
An eye injury is a scary thing for people to deal with. Injuries to the eye can be especially disturbing for a first aid provider. Eyes can be injured in many ways. For example, a little bit of dirt, metal shaving, sawdust, or an object hitting the eye can cause a scratch that can be quite painful and irritating. So make sure the victim does not rub their eyes, as this can cause more damage. Other injuries could include an impaled object like a stick or a screwdriver. Cleaning chemicals, powders, or battery acid can splash into the eye and cause burns that can be very painful and even cause permanent damage. Now, somebody with an eye injury is going to be very scary. Could be because of the pain, but it also could be because of the inability to see well. So keep talking to the victim to keep them calm. Try to avoid wrapping bandages over their ears because it can cause more anxiety for the victim to not be able to see and not hear clearly. An important thing to remember when caring for an eye injury is that the eyes move together. If only one eye is injured, both eyes need to be covered. If you cover just one eye and keep the other uncovered, the uncovered eye can still move around, causing the injured eye to move along with it, thereby causing more damage. When an eye has been impaled with an object, do not pull it out.
Take your patient's
Instead,
hair.
a good solution is to place a plastic cup to cover the object without touching or moving, or putting pressure on the object. Then, bandage around the cup, covering both eyes. Remember to keep the bandage snug enough to hold, but not too tight. A bandage that's too tight can put too much pressure on the eyes and be very uncomfortable, if not damaging. The idea behind bandaging the eyes is just to stabilize and reduce the risk of further injury for the victim until the emergency services arrive. If you have an emergency where somebody gets a chemical in the eye, then bandaging is not the first thing we want to do. First, we need to wash the chemical away using at least lukewarm water for 15 minutes minimally, up to 30 minutes. And if you can use another irrigation solution, you could use saline or pure water or just run them under the tap. If only one eye is affected, tilt the affected eye down while flushing so that the chemical does not get washed into the good eye. Now let's talk about black eyes. Black eyes are caused from a blunt injury, and they're usually minor, but they can result in a significant injury or head trauma. It's always a good idea to see a doctor to rule out a serious injury if you're not sure. But treatment for a black eye would include holding a cold compress over the injured eye for 5 to 10 minutes while then removing it for 5 to 10 minutes. Be sure that the icy solution, if that's what you're going to use, is covered with a towel so that we don't damage the soft, tender skin of the eye while holding that cold compress on. Be sure to look for any of the symptoms like impaired vision, inability to use the eye, there's visible bleeding, or there's something on the white part of the eye that looks like damage, and if there's drainage coming from around the eyelid. Call the doctor immediately or go to the emergency room if any of these symptoms exist.
All right, so guys, if you're putting any type of bandaging or covering or bulky dressing around the eyes, what should we probably use to stabilize it? Instead of tape directly on the patient's head. Yeah, maybe an ACE wrap, maybe Curlex, something that's not going to be as painful when we remove it. Okay. Also, too, you got to think about if you're putting tape directly on the object that's covering the eye, when you go to remove it, it could kind of like tug on it. So just don't use an adhesive when you're trying to secure any type of bandage to the face or the head. Just use an ACE wrap or use Curlex, just so the removal process doesn't cause more pain or more damage, trauma.
Professor A, I have a question about that too. Since we don't want to use adhesives and just a wrap, is it standard for the trucks to come with the kind of bandages that, is it the one that has like the little metal piece that kind of hooks around type situation?
It could be
you know
that.
what I'm talking about?
Yeah, it could be that attachment, or it could just be the strip of Velcro on the end.
Oh, Velcro. Okay. Okay.
Guys, flushing of the eyes, we kind of talked about this in toxicology. If there's any kind of irritant, whether it's a chemical or a foreign object, we want to make sure that, guys, that's the only thing you're going to be doing en route to the hospital is flushing. Literally, he said 15 to 30 minutes for flush time. That's legit. When they get into the ER, they're going to do it even more. All right. So just make sure, remember, if it is just one eye, like he said, when you're flushing it, have the affected eye pointing towards the ground. So the gravity is not going to pull any type of chemical or that foreign object into the good eye. Right. What can we do if it's both eyes? What's the, right? Lie the patient supine, maybe sitting up a little bit, get the prongs for the nasal cannula, run them across the bridge of the nose, and then with a syringe, just push that normal saline or the sterile water through the connective tubing of the nasal cannula, and it will wash both eyes out simultaneously. Okay? Yep, so that's definitely going to be bulky dressing around, or trying to maybe utilize a cup or something like that to protect the movement. Or it's just like the impaled object. Remember we talked about that guy with a knife in his chest? We're going to put the bulky dressing around that, so we try to stabilize the object as much as possible. Same concept here. Just make sure you're covering the other eye as well. Guys, when we were the video was showing the black eyes, right? What did you notice about the sclera? Okay, so bleeding, any type of blunt trauma, penetrating trauma, we do have a vascular supply to the eye, right? So the capillaries around the sclera can burst and can rupture, and that can give you I think it's called petechia when they burst. Sometimes it looks kind of like fireworks, where they just kind of like spread out and have like the spider leg looking effect, or sometimes there's actually like pools of blood around the sclera. So that can come from any significant force. I had food poisoning one time, and they busted because I was like throwing up so forcefully. So a lot of things can cause that, but usually it's secondary to blunt trauma or penetrating trauma. You're typically not going to see any external bleeding from that. It's usually localized in the sclera. Light burns, guys, we talked about this when we were talking about the pupils, right? What can happen if we, stare at the sun for 10 minutes? All right, we can burn, we can have structural damage, or I guess technically, yeah, structural damage to the retina, to those rods, those cones that allow us to be able to perceive vision, right? Because the pupils don't totally close off altogether. right? They can only get so small, which means they can't block light in its entirety from coming in. So, what are you gonna do with this? Guys, I can't make this up. During the last solar eclipse we had, there was an increase in 911 calls for eye injuries, for people not utilizing like the special sunglasses they gave out. And also what? Did I not tell you guys this before? Chemical burns to the eye, because some people thought that they could put sunscreen in their eye, so they
Really?
So, with the sunscreen burn, what could you do for that for treatment? Flush. For the light burn, what are we gonna do? Yeah, just keep the eyes covered, give a sympathetic drive in, right? There's not much that we can do to go in and reverse that damage to those inner structures, such as the rods and the cones and the retinas. Okay. Lacerations, you can have lacerations to the sclera, to the actual, the lens, to the cornea. You can have lacerations in any capacity to the eye. Again, guys, cover the affected eye, cover the unaffected eye. Not much we can do. We're not ever, if there is any external bleeding, not particularly from the eye itself, we don't usually see that a lot, but maybe the surrounding soft tissue. Be very careful when we apply that direct pressure if we're trying to control the bleeding, right? Because we don't want to do what? We don't want to squish the eye itself. So maybe just put a bunch of, like some bulky dressings, get a bunch of 4x4s, place that there, wrap it around with the Curlex, but make sure that we're not applying like an actual pressure dressing around the eye, because we can cause further damage to the eye itself. Okay. What happens if the eyeball pops out of its socket? Because that can happen. Okay. Technically, what would we call that? Maybe that, or maybe technically you could swing it as an evisceration, right? It's protruding from the natural position it should be in. How are you going to handle that? Okay, so maybe lay down. Yeah, guys, first and foremost, the eye is naturally what? Moist. So get a sterile, moist dressing and surround the eye and any of the connective ligaments or tendons or vasculature that is exposed. We're going to wrap those up in a moist dressing to preserve the integrity, right? We don't want to come in with a dried out eyeball. That's not going to be good. But what could you possibly attempt to do next, or what should you attempt to do next? Very carefully.
Lay down. Lay down.
Yeah, so probably we're going to have the patient lie supine. If we can find like a cup on scene or something that's the equivalent of, guys, we're not going to try to do what? We're not going to try to pop it back in there, okay? But we want to bring it as close to that socket as possible, so we're taking away all of the tension and the stretching from those connective structures. All right, so just have it as close to the socket as possible. You can have it kind of resting right here. Again, if we can get a cup, it's really just kind of harsh, but we can just kind of like scoop it up and then just, have the cup lay flush to the patient's face, and then secure it with the Curlex, and then obviously cover the unaffected eye as well.
How many times you actually have a cup?
Hmm?
How many times you actually have a cup?
I mean, guys, you would be shocked. The ability for y'all to improvise with what you have on scene, you're going to become like mini MacGyvers, because you can use a lot of different stuff. We've used, I've seen people use emesis bags, because there's kind of like it's not cardboard, but it's like a reinforced paper at the mouth opening where you can throw up into. You can take that and just kind of like tape it together.
Just think about sterilization of things. I mean, are you taking cups from the patient's house, are you saying, or?
If that's what you got, that's what you got. You can try to wipe it down with like some alcohol, let that dry before you
Yeah.
do anything with it. But yeah, because ideally we're going to have if it's popped out of socket, that moist dressing that surrounds it, so it's kind of a buffer between that and the germs that could be on a cup, I guess.
Okay.
Yeah, you'll learn to improvise a lot, especially when it comes to splinting. Well, we'll get there soon. All right, talked about that. Yeah, guys, this is going to be, if at all possible, do your best to try to assess your pupils when it comes to eye injuries, right? Because if we've got significant involvement of the optic nerve or the retina, we typically, that eye, the pupil will not be as reactive. It'll be more dilated. And we also want to do a quick what? What kind of test? So maybe a follow the finger, see if we're able to move. What else?
Distance.
Maybe. So distance, what do you mean?
Just see if their eyelid, or excuse me, eyelid, if their pupil changes to focus on a point up here versus.
Okay, you guys just do a really quick visual test. There's not like an official visual test that we perform, but you could just do something as simple as what? How many fingers am I holding up? You know, if there's something next to you, if you have a pen, you should always have like 3 pens on you. Get a pen, say, hey, can you tell me what this is? Right? We want to see if there's any deficits to their vision. That's going to be something that we want to relay in the report. You know, positive visual deficits to the right eye, describe the injuries, whatever that might be. Okay, so just do a quick visual assessment. How many fingers? Can you tell me what this is? Or maybe pick something up. Can you tell me what color this is? Type thing. Same concept. Guys, contact lenses, if we have a chemical that is in the eye or a foreign particle that's in the eye, what should we feasibly try to do? Take the contact out. When I wore contacts, there was no way in HE double hockey sticks I would let somebody else besides my optometrist get that close to my eye and remove my contact, right? It's just a very, it's just, yeah, it's personal experience. No, I mean, personal space, not even that, but it's just, it's very, you're very vulnerable. Your eye's going to be doing the whole like blinking and like avoiding that because the brain perceives it as a threat type thing. So what can we do if we can't feasibly take out a contact? Because guys, honestly, if you don't wear contacts, I wouldn't try to do it because you don't really know how to do it if you don't do it day in and day out. Yeah. Hey man, can you take the contact out? Just a real quick, you know, toss it if they want to keep it. Why do we want to try to take the contact out? So it's very possible that maybe if it's a chemical or a foreign particle, it's up underneath the contact lens, and that contact lens is containing that said chemical or that same foreign object, and we want to make sure that we get it out so it doesn't cause any damage. So if feasible, get the patient to remove their contacts. Do not use a small suction cup to remove hard contact lenses. There's soft and there's hard. Hard are less likely to come across, but we don't carry a small suction cup in your jump bag. Don't try to improvise with anything like that either. Just ask the patient to take it out if they're conscious and able, okay? So yeah, we don't carry that. If you guys, when you're doing your ER clinicals, if there is a patient who does have an eye injury, try to shadow that doctor when they go in there. They'll call the doctor in and they perform it's really cool to see it done. I don't even know what the name of the test is, but they put a solution in the affected eye and it becomes like luminescent. They'll let it set in that affected eye, that injured eye, for usually like 10, 15 minutes, and they come back literally with like a black light machine. And the entire eye should light up. It typically presents with like a neon, like a highlighter yellow or green color. If there's any striations in that solution, that tells them, oh, hey, we've got a compromise to like the retina or whatever. It's a really cool test to see done. So if you guys go to the ER, try to watch it if possible. Ever good with eye injuries? Main concept, just, bulky dressings, cover both eyes, and if it's popped out of socket, moist, sterile dressing. Okay. Nosebleeds, guys, we kind of talked about nosebleeds yesterday, right? How are we going to manage this? If we don't have compromise to the bone structure, encourage the patient to pinch that cartilage right there, lean forward so gravity can pull out the rest of the blood. We don't swallow it. There's not an airway obstruction. Guys, be nice and just give them like an emesis bag. What is that? Throw a bag, right? I think now they carry, it's like a circular opening right here, and it's just got a plastic bag that trails down from it. They can just put it up to their mouth and puke in it. Or sometimes they're like plastic bags with like the cardboard. But yeah, just give them that and say, hey, if you have any of the blood come up, just spit it in here. But yeah, we're gonna pinch the cartilage, lean forward, and let the excess blood drip out. One of the most common causes is digital trauma. What does this mean? Picking your nose or having your finger up your nose for whatever reason. Again, guys, there's soft tissue. We've got the mucosal membranes. We've got that soft tissue that lines the inner part of your nose. It's supplied with, vasculature. So if that becomes compromised, it will bleed.
And you said that was digital what?
Trauma.
Oh, trauma. Okay, thank you.
For making your nose bleed by picking your nose is digital trauma.
Gotcha, because you were breaking up, sorry.
Because there is anterior and posterior, just depending on what aspect of the nose is affected. Again, if we can, pinch the cartilage. What if we do have like a broken bone up here or significant damage to the cartilage and we're not able to do that mechanism? Just get some 4x4s and just hold it up against the exterior part of the nostrils and then have the patient lean forward like you would, if we were able to pinch the cartilage. So again, guys, all these little bones right here that make up that sinus cavity, we are concerned if it's a significant force, like blunt force trauma. Yeah, we could have these exterior bones affected, but if that force continued back, those very small bones that make up the sinus cavity could be affected. That's going to be a contraindication. Obviously, guys, if you've got a broken nose, we're not going to place a lead. NPA, right? But that is how we can start to have airway compromise if some of those bone pieces or fragments or the blood from that starts to drip down into the airway. So again, going back to your trauma assessment, if we have any blood coming from the ears, the nose or the ears, all right, what do? We test that blood, right? We do that halo test. We saw a positive halo test yesterday. Get a 4x4, just kind of, roll it up, so absorb some of the blood that's coming from that orifice. See if we've got that CSF present. Guys, if we have the CSF present, what does that mean? So we've got a significant head trauma. Okay, we're going to talk about that next chapter. But the protective layer around the brain that helps contain that CSF has been compromised, has been ruptured, and that's not good. That takes a lot of force to do, and then we're going to worry about the status of the brain itself. Everybody good with the nose? Not a whole lot we can do. Just try to control bleeding and be conscious of the airway status. All right, so with the ears, we have the outer ear. So coming up to that tympanic membrane, to all of the canal here, and the external ear that you see is going to be the outer ear. Guys, what is this made up of? Cartilage. Okay.
Cartilage.
We can't break any bones in our ear. We can just have that soft tissue damage that we can control the bleeding. The middle ear is, and the inner ear are where we start to get all of these itty bitty, like the stirrup and the anvil, the hammer. Did anybody play Operation? Those those are some of the parts that you can remove, like the teeny tiny bones. But the cochlea is the kind of the receiving, processing parts to make sure that we can hear. All of these bones and the tympanic membrane help control with the vibrations to aid to being able to hear sounds. But this is where it's mostly done. You might see patients with a cochlear implant. If they had an injury that made them deaf or they were born deaf, they can actually implant a new cochlea to help aid with hearing. They'll typically have like a device that's secured right here to the head. But yeah, so with the ear, guys, what are some of the injuries we can see? What are some of the causes of injuries? Okay, so ruptured eardrums. So ruptured tympanic membrane, so maybe from like a blast injury, right? What kind of blast injury would cause this? Primary, that barotrauma from the explosion itself. What else?
With an ear infection, eardrum.
Okay, so an ear infection, that's more of a medical etiology, but yeah, an ear infection can compromise the status of the inner structures. What if we get something just kind of jammed in there? Right? Yeah. Okay, that can definitely, penetrating trauma can cause injury. What else?
Lacerations or damage to the outer ear.
Okay, yeah. Yep, nope, that's the thing. I've had that call. It was a roach. Mhm. I didn't follow up with a patient. But you could see, you could see the little feet. Disgusting. There's one that I've seen on Reddit. It was like a spider.
Yeah.
I guess that's no. What else? Yeah, what if we have that, what are we gonna do? I look at goosebumps. Nothing. You're not gonna get like tweezers and try to get it out, like you're just, and I can't imagine, but the patient's gonna be freaking the F out. What other situations can cause barotrauma? Do it. Yeah, a lot of underwater pressure. Okay, so you're not gonna see it so much here with like scuba diving or something like that, but even like younger kids, if they jump, because I had, what's it called, swimmer's ear, where the chlorine, it would get in there and it would really irritate it, and every time I would go like in the deep end, it would hurt a lot. So sometimes if it's like a significantly like deep end of a pool and they go to the bottom, that pressure can cause some damage.
I was on a 4-day scuba trip, and the very first day I ruptured my eardrum.
You know,
And it
ow.
was just painful.
Yeah.
I see you bleeding for like the rest of the trip.
Yeah, guys, it is extremely painful. Okay. My husband got hit in the head with a baseball bat by his brother when he was younger and partially tore his tympanic membrane. He said it was excruciating. You will see some blood coming from the ear for sure. But yeah, that's his excuse for, I didn't hear what you said. There's scar tissue in that tympanic membrane. That's his excuse for selective hearing. But guys, there's not a whole lot we can do for this stuff, right? If we have a penetrating object, what do? Stabilize it with bulky dressing. This is different from an eye injury. We don't want to cover up the unaffected ear because again, that's another source of hearing and seeing another sense that we're taking away from the patient, and that'll send anxiety through the roof. So for this case, just cover the affected ear. Again, CSF coming from the ear, not good. We've definitely got something going on with a head injury. All right. Facial fractures, again, guys, our major concern, airway, okay? We can't physically do anything for a facial fracture. We're not gonna be able to splint a zygomatic arch. We're not gonna be able to do that. If there's any soft tissue damage, we can control that. Be mindful if we do feel crepitus or instability to the underlying bones. Make sure we're not applying too much pressure to that soft tissue, so we don't cause further damage, further area obstruction, all that jazz. Okay. They're gonna, yeah, if it's facial fractures, they're gonna need reconstructive surgery. There's nothing that we can do besides bleeding control and airway management. Talked about that. Talked about that. Injury of the cheek, what do we talk about here? Is important to know. If you have an object impaled in the cheek, we can remove that object, and how are we going to control the bleeding? Inside and outside. Okay, so if your patient is conscious and able, give them 4x4s, and then just have them on both sides. Tell them to kind of pinch that area, or that's how you're going to handle it yourself. It's just 4x4s. Make sure we don't like choke the patient out. Right, the 4x4s on the interior part need to be folded up to a smaller capacity, so we're not obstructing the airway. Oh, the neck. Again, guys, there's all sorts of things that can play into a neck injury. We could have the soft tissue. We could have the vasculature. Guys, if we have a nicked or lacerated carotid artery, what do? Drug pressure, drive really, really fast, right? Yeah, if we have that quick clotting material, we can place that there, but can't place the tourniquet on the neck, right? Everybody's clear on that? Everybody's clear on why we can't do that? Okay, which leads us into tracheal trauma, right? The cartilage rings, the membranes in between. Guys, if you have a patient with a collapsed trachea,
Get ALS.
hopefully ALS is really close by. Okay, because what we can do is we can do a crike, a surgical crike. We can find a cartilage membrane, hopefully ideally below that injury, and we can insert an airway, like a smaller tube in that cartilage, and bypass that damage if that's the location's ideal. Talked about that.
Does like positive pressure help with that? Like if you're bagging a patient, will that kind of like reopen that, or is it?
Typically not. If we have any compromise to those cartilage rings, it doesn't really. I mean that.
It's like one of those hoses that got ran over by a car. Like a hose that gets run over by a car, like it's crimped, can't recover it.
Yeah, it doesn't pop back up to its normal structure. Subcutaneous emphysema. What is that?
Like the air under the skin?
Air under the skin. Guys, what is this gonna look like? Can you always see it? Not really. Sometimes the area can look swollen. You typically discover subcutaneous emphysema by palpation. All right. So if you're palpating the neck or you're palpating the chest, we see it in the chest a lot with what injuries? But we have to have a what to have a sucking chest wound? Pneumothorax. Okay, so any abnormal air that's escaping into the skin is going to cause subcutaneous emphysema. It's really cool to feel. It sounds like morbid for me to say that, but when you palpate and you feel subcutaneous emphysema, it literally feels like you've got a Ziploc bag full of Rice Krispie cereal, and it's kind of crunchy and poppy when you palpate it. So guys, if we have positive or present subcutaneous emphysema, we can infer that we've got air leaking somewhere that it shouldn't be. Okay. This can come from a neck injury that's compromised the airway, or it can come from a chest injury that's compromised the lung. Subcutaneous emphysema is going to be air leaking where it shouldn't be leaking, which indicates compromise in some aspect of the airway. If it's in the neck, it's the trachea. If it's in the chest, it's the lungs. managing that in a little bit, but that's what it is, that's what it means. Direct pressure, if we have lacerated vessels. Can't do anything about that. Talked about that. Again, guys, here's another exception. If you have something that is impaled in your patient's airway, and it is affecting managing that airway or CPR, you can remove it. All right, so if you've just got a 2x4 picket, I don't know what that could be, but if you cannot manage your patient's airway successfully, we can remove it so we can try to manage that patient's airway. We got a lot more problems if we have a 2x4 sticking out of your neck, but you know. If you're still able to move some type of air, if the patient's breathing any kind of way on their own, or you're able to get some sort of chest rise, if you're bagging them, leave it in place, stabilize it with bulky dressing, and just do your best to manage the airway before you get to the hospital. Guys, if we have a neck injury, do you think they're gonna have difficulty breathing? Yeah.
Yeah.
We have some internal swelling, so maybe if they are able to speak, it could sound very scratchy or very hoarse. But yeah, pain, difficulty swallowing, cyanosis, all of that stuff that comes with improper oxygenation. Is that fair enough to make that connection? Also, too, guys, if we've got this significant damage to the airway, we probably want to do a very thorough assessment of what? C-spine. If we've got that much trauma, that much force to cause a significant airway issue, then yeah, we might have some subsequential neck injuries. If that's present, we need to place a C-collar, but just be mindful that that can sometimes limit the way that we can manage the airway. But it's just going to be one of those things. How do we judge our treatment? We treat what?
What's gonna kill them first?
What's going to kill them quicker? Right? So just use your best judgment call with that. If you can't properly manage the airway with a C-collar on, is that a problem? Yeah. Okay, so maybe we can try to, as best we can, maybe manually hold C-spine if we can't manage the airway with a collar on, but that's just going to be you learn to improvise and make that judgment call. Question? Very good? Pretty easy one. Just control bleeding and protect the airway, right?